Good afternoon, everyone. Thanks so much for joining us today for our lunchtime webinar. I know that many of you have very full plates, so very much appreciate you taking the time to spend your lunchtime with us. So my name is Anna Dion. I'm a knowledge broker with RISE based at the Ottawa Hospital Research Institute on the traditional and unceded lands of the Algonquin Nation. And I also am joined today by Carrie Waddell, who's also a knowledge broker at RISE, based out of McMaster. And we have the great privilege of being joined today by 4 panelists from across 2 OHTs, from Cambridge North Dumfries OHT and from the Ottawa Health Team Équipe Santé Ottawa. And I will introduce them properly a little bit later in the presentation. But they have generously agreed to share some of their insights about community engagement in the context of COVID restrictions. So many of you will recognize the emphasis and push for community engagement and patient partnership within OHTs. And it, from the ministry's perspective, is really a core component of what OHTs need to deliver on. In terms of sprinkling community engagement throughout all aspects of OHT's work, as well as you'll surely remember, having to answer discrete questions about engagement with particular groups to support the implementation of OHT's work. And this is recognized from in alignment with the Patient Declaration of Values that Ontario Health teams must demonstrate that they have meaningful community engagement, both with Indigenous communities and nations, racialized communities, and Francophones. And this is really building on the understanding that to have the transformative effect that is hoped for through Ontario Health teams, we really have to be working together as a community and really almost at a population level to get those gains for OHTs. And so this concept of patient and community engagement relates to what we call building block 3. And building block 3 consists of both patient engagement and community engagement. So we won't spend too much time on patient partnership today, as it deserves its own webinar and series of webinar, but I wanted to briefly mention it here as a critical component of building block 3. And across many OHTs, we've seen patient partnership come in many different forms. And when we speak of patients, often we actually mean patient families and caregivers, so the full spectrum. And many are included in governance and leadership positions across OHTs. Some OHTs are co-led by patient families or caregivers. And others contribute or lead to focus working groups across all of the different decision-making tables within an OHT. And just want to highlight that the engagement and meaningful inclusion of patient, family, and caregivers is also critical in the shift towards a population health management approach. And in particular, in understanding patient population needs, the experiences of care, and how to improve services to better meet those needs. And this comes out particularly in reference to how OHTs can meet the requirements that are set out by the Patient Declaration of Values in ensuring that all Ontarians have equal access to care, regardless of language, ethnicity, or location within Ontario. And this aspect is critically important to the vision and success of OHTs. So I'm not going to spend additional time here on the particular dynamics and role of patient partnership, but did want to just emphasize its critical place in the success and implementation of OHTs. And so today's webinar really focuses on community engagement and what good and meaningful community engagement looks like. And the way that we have operationalized and think about community engagement is really around engaging diverse groups in the community and thinking about how to engage them across the spectrum of OHT activities. So in decision-making, planning, and design of services and the governance of the OHT itself. And this is really an opportunity to think through who has who has traditionally been at decision-making tables and whose voices and perspectives typically aren't heard in decision-making structures and at different levels, and really inspect whether there's voices that we haven't had at the table and that need to be heard if we want to do a better job at creating a system that's both more accessible, more responsive, and that better supports outcomes for all Ontarians. And so for today's webinar, we're really going to try to unpack what we have learned about what good community engagement means. And so we'll focus on these three last bullet points on this slide. So building relationships with the full diversity of community groups, being explicit about the goal of any community engagement initiatives, and really being intentional in the design and taking care to think through the different needs of different groups. Okay, so if we move to the first part of building relationships with the full diversity of community groups, when we think about, so starting from a place of asking what is community and how do we define that? And we're really thinking about this as groups that share certain characteristics or interests. So this could be around age, sexual orientation, gender, ethnocultural background, language is spoken at home, having lived experience with a condition or a particular social determinant of health, or people who identify in relation to different intersections among these characteristics or interests. And so working to take a really inclusive definition of community while also paying attention to the unique contexts that different groups face. And you'll see here that we bolded both ethnocultural background and language spoken at home. And this is just to emphasize the two particular community groups that have received specific focus by the ministry and, as you will have seen on the full applications, one being Indigenous communities and nations and Francophone Ontarians. And while we don't have the opportunity to go in detail about engagement with these groups, in this webinar, we're also working to provide resources to support OHTs in engagement with both Indigenous communities and Francophones. Many of you will know about the offer of Indigenous cultural safety training that's currently underway, and also working to provide a focused webinar on engaging with Francophone communities later in 2021. The full application and the ministry also recognizes that each OHT may have specific communities that may be part of their priority populations or that currently lack access to care that could also particularly benefit from an OHT model of care. So just thinking broadly and in your own context about which communities may most benefit from an OHT model of care. And in that same vein, we've included on this slide a couple dimensions to think through what community groups might look like. So they can vary from being very informal, meeting in a community center as a self-organized group, or they may be more formal with their own governance structures. Some may be run on volunteer power, while others may have professional staff, and many have a mix of the two. Also think about organizations that many community-based organizations follow a not-for-profit model, including community health centers, which have an important role in many OHTs, as well as for-profit organizations, which sometimes are excluded from our thinking when we think about community groups, but it can also play an important role as we think about engaging them. And so again, this list isn't exhaustive, and there's certainly many other dimensions to think about and consider when thinking about community groups, but just wanted to lay this as a foundation. And so the next slide really talks about, excuse me, being explicit about community engagement, being explicit about the goal, and being clear about the commitment that comes along with that goal. And so in this table, we've included several approaches and goals to community engagement. And as you go down the table in the first column, there's increasing collaboration and power sharing between partners. But I do want to emphasize that all levels of engagement each of them has their appropriate place, and they all add value. And it's really the key is about tailoring engagement strategies to your purpose to make engagement meaningful. So if we just go quickly through a couple examples, if we think about the first row around sharing, so this may be where community groups receive information about a program or decision from an OHT in an accessible and tailored way. So this is really a one-way push out from the OHTs out to community groups, and is actually a really critical type of communication that sometimes gets dismissed, but is really important to the work of OHTs and building awareness of how OHTs are operating. The second row is around consulting, and so this is where OHTs take more of a listening position to incorporate the perspectives from community groups, as well as, importantly, feeding back to community groups how their input influenced decisions. The third row is around deliberation. So community groups both help define the issue and help develop strategies that OHTs commit to deliver. And so this is where engagement partners take more of an active role in both shaping the conversation and finding common ground with the OHTs for implementation. The fourth row is around collaboration. So where community groups work with OHTs to define, again, both what the root problem is and look to their engagement partners for innovative solutions, and work together to find an implementation strategy that accounts for those. And this is really a comprehensive approach to engagement that's about co-ownership of solutions and co-design that come into play. And the last row of this column is really around flipping that dynamic. So where community groups really lead the decision making and OHTs take more of a support and contributing role. So this might be something where OHTs are in a supportive role of an initiative that's led by a community group, so they provide their input, but the community groups are really at the decision-making position. And so in thinking these through about different approaches to community engagement, it's really important to be explicit about where along this continuum you fit as a goal for the engagement initiative, and recognizing what that message, how that message is presented to community members. And so just coming back to this idea that each level has value, and it's really about navigating that space between meeting OHT's objectives and as well as recognizing that many community groups have their own mandate that may overlap only in part with OHT's objectives. So recognizing the demands on time and space on both sides. And so as the next stage, we wanted to talk about what it means to be intentional in the design of community engagement initiatives. And this really comes down to both individual and institutional attitudes and how we conceptualize engagement, and requires a genuine commitment to self-reflection and thinking through some of the assumptions that we may have about the best ways to engage with groups. And so the first point we wanted to raise is just thinking about, are we asking if we're modeling an openness to having stories told and issues reframed and having our understanding about particular issues challenged? Are we able to recognize community stories as the gifts that they are and incorporate that into our work? Are we demonstrating a commitment to being as systematic and transparent as possible in terms of decision making and how input influences that? And this is, I think, a particularly tricky one, particularly for recently approved OHTs, as many teams are working towards developing effective shared decision-making strategies within their own teams, and then extending that to community groups in all of their diversity is extraordinarily challenging. But I think the key there is the commitment to do it, and to do it systematically and transparently with all partners, about what you've been able to accomplish and what you haven't, and just being very honest about where gaps are, and addressing those gaps as a priority. And the third point here comes back to the question of openness. And so, are we showing a willingness to adjust how we design programs, how we deliver, how we make decisions, how we operationalize engagement? So it's one thing to say that we want input from a particular group, but to have that fall on deaf ears and not demonstrate a willingness to adjust programming really doesn't demonstrate to the community that the intentions are a true one. And so this is really just a question of every once in a while to have a feedback loop and just check ourselves, check our processes, check how we're working to make sure that input's heard, acted upon, and those changes are maintained, and that communities have continued opportunities to feed into that process. And the final point on this slide is really thinking about how the opportunities that OHTs have to provide future leadership opportunities for members of underrepresented groups. So this might not be at the forefront of your thinking as you're working to engage communities, but it's certainly an opportunity that the OHTs can provide, and thinking about how we can develop capacity for leadership, what do underrepresented groups need in order to be engaged and become leaders and to be at the table. And this also requires us to be very cognizant of the power dynamics that exist in the system, and thinking through how we can address those in the short term, but also thinking more long term, and what ground we can lay to build up for the future. So a couple other prompts that we wanted to raise around being intentional in the design of community engagement initiatives, and I won't go through all of these, but just encourage you to think back about goals and focus in relation back to the table that we looked through about the continuum of engagement goals. And thinking about, so are we clear about, and thinking about recruiting in ways that respect diversity. So again, how are we trying to engage folks in our health system that aren't benefiting from the services that we could be providing? And how are we providing supports to address some of those barriers? So some of those supports can look like targeted capacity building, thinking about the type of language we're using, whether it's technical language, as well as having opportunities for translation. Also thinking about how people may engage differently, whether it's having different abilities or different forms of learning, visual learning, audio learning, different types. So presenting different information in different ways. It's also really important to respect anonymity where that might be important. So in some cases, engaging in a particular initiative may have the consequence of identifying someone as part of a particular group, and just respecting and thinking that through if respecting anonymity in that context is important. And also thinking about if we're engaging folks on an issue that might invoke particular sensitivities for them, have you considered things like backup counseling or other resources in the case that the act of engaging around this topic results in unexpected stress or burden for them? And so these processes of thinking through and taking extra care that are really critical to ensuring that people are heard, are comfortable, and are willing to come back to the table. And sometimes this means traveling outside both our professional and physical boundaries. So going to where communities are, and where that community gathers, and taking the time to understand how that engagement might be most effective, instead of expecting communities to come to us. And so the last slide about being intentional in design is really around thinking through each step of the engagement process. So are we using a clear process? Do we have the people around the table that have the skills to lead this Do we have enough time? Is the venue appropriate? So coming back to some of these issues around being thoughtful and care for the community. And then the next point comes back to the idea of feeding back in and making changes. And this is really a critical piece to propelling future engagement and making it worthwhile for those you're engaging with. If you can demonstrate that the input you've received was heard, reflected on thoughtfully, and what action steps have been taken, and if you haven't been able to take those action steps, explaining why not. And this is really important in creating both the buy-in in the process and creating interest in future engagement and getting people on board to what you want to do. And really is a fundamental, just a respectful way of conducting engagement. And then the last point we wanted to raise here was taking the time to formally evaluate community engagement initiatives, to really understand systematically whether your engagement has achieved the goals it set out to, and whether people participating got what they wanted or needed out of it, and if not, why not? And there's many, many tools available to support the evaluation of engagement initiatives. On the RISE site, we do have posted the patient and public engagement evaluation tool, but there are plenty others out there. And so we just encourage everyone to consider to match engagement goals and processes with particular evaluation tools that may best serve your purpose. And so we wanted to give an overview of what community engagement might look like in the best of times, but also wanted to recognize that many things have changed in the context of COVID and responding to the pandemic, and particularly since March, have seen a huge shift in both people's professional and personal lives from an in-person context to one that has shifted largely online. And in many cases, we saw engagement decrease, both within OHTs, but really across the health system as many people rightly turned their attention to the management of the COVID pandemic. But we've also seen several examples of really meaningful engagement that was possible around particularly urgent questions. Some of those around the role of caregivers, particularly in long-term care homes, and the vulnerability of marginalized and underserved groups. And so many of the questions that we've just gone over around meaningful engagement still apply, but certainly there's new questions that need to be asked in the context of COVID. And so we've outlined only a couple here, and I know that our panelists will provide additional insight into some of these questions and how they may have answered them. So really thinking about, is this the right time for engagement? Many people have taken on additional care responsibilities, family members or others at home, and community organizations are dealing with a whole new level of both demands and barriers. And so is this the right time to ask people to engage? And who might we miss if we try to engage communities right now? On the flip side of that, there's also, are there urgent issues that need community input right now? Where we see change that needs to happen and communities need to be at that table. We also have to think through new or different barriers to engagement because of the reliance on internet connectivity, having to think through communities that may rely on public space for internet connectivity that they may no longer have access to. Linguistic accessibility online is different than in person, and also strategies to build trust in online communities. And just to say that many community organizations have not stopped engaging with their community. So often those community organizations are best placed to advise and potentially for OHTs to leverage in terms of reaching and engaging with those communities. And then if and when we're in a space where we're able to convene public events again, just rethinking some of the supports that may be needed for people to engage. So including budgets for safe transportation, protection equipment, and other other strategies that we may need to put in place to support people to engage. And so we just wanted to provide a little bit of an overview of some of the tools and strategies that we have to engage, particularly in the context of COVID. So many of the strategies and concepts remain the same, and they can be adapted to either an online digital space, or continuing to engage with some of the non-digital tools that have served us well in the past. And so highlighted here some of the non-digital tools, and also wanted to highlight some of the tools that are increasingly playing a larger role in our interactions and engagement. So we'll starting just thinking about social media, and I think many of us have seen the power of Twitter. I know I will forever be grateful to Twitter for much of my education on many topics. And just thinking through how we engage with social media, this comment about gamification is ways that we can incorporate nudges or badges that people get for interacting with content. And then moving further down the engagement continuum, thinking about more interactive platforms where people can host conversations, work through issues together. And then thinking about many online collaborative brainstorming and project planning tools are both open source, so freely available, certainly require a little bit of a learning curve, but I've seen many successful collaboration initiatives that have used these types of tools. And so now I will turn to our panelists who have really been living this reality for the past several months to hear about their own experiences and learn from some of their wisdom. So I will turn to the Cambridge North Dumfries team first. And so I'd like to introduce Christina Eliashevsky, who's the transformation lead for the Cambridge North Dumfries OHT, and Elaine Shantz, who's the CEO of the Fairview and Parkwood Seniors Home.
Hi, Anna. Thanks so much for having us. We're so grateful for the opportunity to share our experiences, pivoting our approach to engagement to meet the needs of our most vulnerable groups during COVID-19. And so Cambridge North Dumfries was one of the first cohort of approved OHTs, and I see that we have participants from all over the province. So for those who might be less familiar with our region, we're located in Southern Ontario between Toronto and London, just neighboring Kitchener. Our services cover the city of Cambridge, as well as the rural township of North Dumfries. Like many Ontario health teams, our leadership group quickly pivoted the focus of our OHT efforts to COVID-19 response in mid-March. Our steering committee identified a number of emerging needs in our community related to the pandemic, and so we adjusted our work accordingly. The steering committee began meeting weekly in April and May to collaboratively review system capacity, check in with members, and soon in these conversations, long-term care homes and retirement homes were identified as a priority area. The CND OHT is very fortunate that we have 2 long-term care home members of our OHT who early in the pandemic response identified the vulnerabilities in these settings and the opportunity to develop supports and engagement mechanisms to connect directly with homes, even beyond our OHT membership. Working along our regional OHT colleagues, and I see my colleague Ingrid on the line from Kitchener, and our IMS support structure in Waterloo, Wellington, a cross-sector congregate setting huddle was put in place to review the status of each home on a daily and then weekly basis to collaborate on appropriate interventions. The structure worked well and continues to function to quickly identify emerging issues and address them in partnership with the Ministry of Long-Term Care, the Retirement Regulatory Authority, Public Health, our local hospital, home and community care, and other system stakeholders. Although it was a thorough and collaborative approach, one gap in our structures identified early on was the need for direct engagement with long-term care homes and retirement homes. We identified that although long-term care and retirement homes were receiving outreach from our partners, It was not purposefully coordinated, nor did it meet the functions of engagement and partnership that we felt would be able to support our response efforts. When considering our engagement with stakeholders from an OHT perspective, I do find it helpful to gauge our efforts against the Ontario Public Engagement Framework, and it's similar to that framework that Anna just showed us. We felt that we were sharing information appropriately, but there was a lack of the consultation piece, the deliberation, and meaningful collaboration in our OHT's approach to supporting long-term care homes and retirement homes through COVID. To address this opportunity to enhance engagement, working in partnership with our long-term care home OHT members, we established a weekly long-term care and retirement home, Cambridge North Dumfries OHT Community of Practice for Home Administrators. We set out the objectives of the forum as an opportunity to share and consult on OHT updates, create space for peer-to-peer support, and collaborate on issues that impacted all homes to drive action. During the first wave, the meetings focused primarily around discussions of operationalization of the new directives and navigating the volume and pace of updates. As the group slowly developed trust, the group evolved to sharing concerns and issues, and we collaborated on issues escalation, including submission of a memo to Ontario Health West regarding testing and testing turnaround times in long-term care settings. And we also escalated concerns around isolation on residents through our IMS structure. As we entered into a bit of a reprieve in outbreaks in the summer, the group turned to preparing for a second wave of COVID. In collaboration with system partners, such as our local public health unit, the OHT launched a preparedness survey for our local homes, focusing on understanding readiness and identifying opportunities for the system to most effectively support the settings in a second wave. We were delighted that despite being a summer online survey, and we know how responses can be to those, 85% of the long-term care homes and retirement homes in our region participated in the survey. And in that, they identified that IPAC and access to IPAC expertise was their top concern for the second wave. In response, our OHT launched a series of IPAC forums that brought together expertise from Public Health Ontario, a nurse-led outreach team, and our local hospital to ensure that all homes had access to IPAC expertise to address their emerging needs. Another insight gleaned in the consultation with homes around system support was the ask for one point of contact to navigate support from our partners. We had previously established, with our good intentions, that homes could reach out to any partner for support. However, meaningful engagement directly with our stakeholders uncovered a quick win opportunity for improvement that we quickly operationalized to support our strategy. The Cambridge North Dumfries Long-Term Care and Retirement Home Community of Practice continues to meet, and it is encouraging to see that homes see the forum as an opportunity to raise questions and concerns. Most recently, there was an ask from members to invite public health to the table so that homes could receive information directly and also consult on issues related to public health's approach locally. We are extremely grateful for this partnership with the Region of Waterloo Public Health and the opportunity for community engagement and the relationships that have been built to ensure meaningful ongoing engagement across our partners. A special feature of our engagement approach was that our actual approach was co-designed with one of the stakeholders that we're meaning to engage. And so I'm delighted to have Elaine Chance with me today, who will speak from a long-term care perspective about this engagement.
Good afternoon. It's good to join you today, and thank you, Christina. I come from Fairview and Parkwood communities. We are a not-for-profit organization, a campus of care, and we do provide home and community, independent living, affordable housing, retirement, assisted living, and long-term care. And when the opportunity, just kind of stepping back to that engagement to participate in the Cambridge North Dumfries OHT, when it was in front of our organization, we really wondered how we would fit. As many long-term care homes were not sure whether they were ready to be engaged. And for us, part of it was the engaging community of Cambridge, where we are involved, the focus on the frail and elderly. And we also wanted to be there to help to shape the future. And who knew that COVID would strike? And being part of the OHT, I have to tell you that very genuinely, it's the best thing we could have ever done. As long-term care, specifically in retirement homes, became very vulnerable in the province and very vulnerable to this pandemic, being part of the OHT has created 3 opportunities for us. And when I speak to it from the perspective of impact, it was relationships, communication, and innovation. And Christina has touched on all of these. With our community of practice, Christina, as our transformation lead, has become our two-way communication point person. And for those who are familiar with long-term care, we had directives and instructions and memos coming from every direction. And we've been able to facilitate those through our community of practice and through our OHT and through Christina. So for example, when our home experienced an outbreak, which was fortunately a contained outbreak, I was able to reach out to Christina and say, here's the lay of the land. Here's where we're at with HR. Here's where we're at with PPE and with IPAC. And she was able to help facilitate and become that one point person. And by the same, I was able to reach out to other partners in the OHT. Through the relationships, I've gotten to know the hospital CEO well. And right away, he said, Elaine, what do you need? I'm there for you. How can we help? And we had lots of informal engagement as well, which was supportive and gave us definitely peace of mind. We've spent a lot of time as well as a community of practice sharing policies and procedures. And that's been incredibly important, especially for the small community, the small homes. I've been able to share with other homes, and there's no need to duplicate the writing of those many COVID policies that needed to be written. And then even if someone couldn't attend the weekly meetings of the community of practice, they could still be engaged through Christina in forwarding minutes and decisions made. And then I think one of the neatest things was innovation. We actually take a little bit of pride in being innovative during COVID. We were able to advocate that, for example, in wave 1, that hospital admissions wouldn't come into long-term care without the testing and without isolation protocol. And sometimes we'd like to believe ours was one of the voices that was heard through Christina to the non-hospital table, through the triad, to make change that really helped our vulnerable population. The testing challenges that we had in the beginning as a group, as we came together and with Christina facilitating, we were able to write a paper. And it did land me on 2 more committees with regards to the testing strategy, but we really felt like we had a voice. And with essential caregivers, when that was new to long-term care, we were able to work together and look at the challenges. So I have to say that being one of those community groups, being part of the OHT, I think that our opportunity to be engaged through COVID and to engage others in the community, both as receiving support, peace of mind, sharing of resources, but then also to be able to give back to other members of our community, such as shelter care and some of the smaller groups. So it's been an incredibly positive experience for us. And I do think that what we've done through COVID will help to shape the way our OHT moves forward in the future.
Great. Thank you so much, Christina and Elaine. That was really inspiring and great to hear of your really important work. So now I'll turn to the Ottawa Health team. Leslie Wells, who's the implementation lead for the Ottawa OHT, and Kelly Donner, who's the executive director of the Southeast Ottawa Community Health Centre and the COVID operations team lead. So I'll advance your slides and just let me know when you'd like me to go forward.
Awesome. Thank you. This is Kelly, and Leslie and I are really happy to be here today to share with you the work of the Ottawa Health team. We were also one of the first approved OHTs in that first wave. And like Cambridge North Dumfries, we identified a critical need to pivot and engage with our community to design a different strategy than in the first wave to respond to those disproportionately affected by COVID. We also created an emergency response structure from our OHT membership that includes leadership, planning, and operations. And while we started off meeting, I think, daily, and then 3 times a week, we are still meeting twice weekly. And I'd just like to note that in Ottawa, we have really capitalized on an already great foundation of relationships with our community, deep connections and networks, and the great community development work to ensure that those most at risk of contracting or being exposed to COVID are provided with critical supports to mitigate or manage throughout the pandemic. Next slide. We have partnered with our Ottawa Local Immigration Partnership, which is a group of 60+ organizations. And recently this group hosted a community forum with community leaders to just check in and ensure that what we're hearing, what we're learning, what we're doing, that it all aligns in terms of our strategy. Many of our partners have not stopped working directly with our community or engaging. And our our OLIP online forum really affirmed that, like elsewhere in Ontario, Ottawa is seeing higher rates of COVID in communities that are more diverse, in areas where there is lower income. And there was an affirmation that the root of these impacts is health inequities and structural inequities, and that any strategy needed to address some of those things. The conditions of work and life were sources of vulnerability for these communities. And OLIP has done some great work collecting data and sharing this with the OHT partners. Next slide. We have designed a COVID community response, a strategy that is directly a result of learning from our community, learning from our community leaders, learning from forums such as OLIPs, learning about what people are experiencing during the pandemic, what the barriers are to preventing exposure or acquisition of COVID, and what they were suggesting were the solutions. So how to respond to that, how to correct the inequities. It's resulted in a multi-pronged strategy that includes a neighborhood response. So response teams that go out, boots on the ground, and do door knocks to provide information, to link people to resources like food and counseling, to provide easy access to assessment, nursing, and COVID testing where needed. We've also prioritized testing both through a mobile team and our fixed sites to support those who might face barriers, including things like not being able to navigate the online tool, not having the language, perhaps not being able to get to a fixed site, issues or challenges with transportation, childcare. And we are really working to capitalize on existing relationships of trust that we have in the community via frontline staff, resident leaders, community and faith leaders, to really get the message out to these disproportionately affected communities that we're here to support you and that we will do what we can to wrap you with supports in the event that you are tested and isolating or exposed to COVID. Next slide. We have also developed a direct referral pathway from our Ottawa Public Health contact tracing and case management team for people who are identified as COVID positive or at high risk of being a contact of somebody who is COVID positive that is also facing barriers to isolating safely. This is done via a network of partners to respond to those people that need these wraparound supports. Some examples of the kinds of supports that we've been able to provide to these individuals are access to our mobile testing team, connecting a 70-year-old gentleman with language barriers to housing supports. He was at risk of eviction. He was also COVID positive. We are supporting quite significantly with access to basic needs, so access to food, working with our employment and financial services branch through the city to access emergency funding, and really doing a lot of assurances and mental health and counseling support as well. Next slide. Fundamental to the OHT's COVID community response is really going out to where the communities are. We are using Ottawa Public Health data around our COVID clusters. We're working with a coalition of agencies that are members of our OHT, using their intimate knowledge of community and how they worked even pre-pandemic. And designing response strategies that are custom to those areas. So, you know, coalescing teams of people in Francophone communities that have those languages, where we know there are multicultural communities, ensuring people on the team speak those languages, having quick and easy access to intake and counseling supports. And we're really partnering with our resident leaders, so our community associations, our apartment building associations, working with our faith leaders and community leaders and community agency staff. So when you see a team out on the street doing door knocks, you don't know what agency they're from, you don't know if they're a paid staff or if they're a community leader, but you know that they're all out there trying to do their best to support people that need us the most. And it's quite remarkable to see everybody come together as one team with a real strong mandate to ensure that people out there know that we're here to support them. Next slide, and I'll pass it over to Leslie.
Thanks, Kelly. So the third prong of our COVID response is a really targeted testing strategy. So this component really came to life earlier in the fall when the province was still doing asymptomatic testing, and the testing system was under a significant amount of strain. We saw a priority need for testing resources to be allocated not just to the general public, but to make sure that there was specific testing capacity for communities that were disproportionately impacted. So our strategies focus not just on the provision of testing, but health promotion and easier access to that testing, with the goal of connecting individuals and families to testing that meets their needs right when they need it. So it's centered on the principle that community members not only need to understand public health guidelines and the need to get tested, but also that there are supports available to them if they become ill or they need to isolate. So to move the strategy forward, we use a combination of approaches. So in addition to the official assessment centers in Ottawa, we've put fixed site testing clinics in downtown community health centers that are easily accessible to many of the communities that we're working with. And not only can they get tested there, but they can get directly referred into the wraparound supports that Kelly was talking about directly from those community health center testing sites. We also have mobile testing teams that can be dispatched to neighborhoods that are experiencing a high volume of COVID, or to congregate living settings that require testing. And lastly, we've recently started doing community-based testing sites in high needs communities that are implemented directly in conjunction with outreach and health promotion strategies. So we learned early on that just plunking down a testing site in a neighborhood wasn't particularly effective. We really needed to do that engagement and that outreach up front to build community awareness, to answer people's questions, and drive them to that testing site when it became available. So we've seen greater success with those community-based sites since we started doing the engagement alongside. Next slide, please. And through all of this, we've really been able to make a significant impact at the system level as well. So bringing what we're learning through community engagement up to the various regional and city level pandemic response tables that direct the community's pandemic response. And since we've started doing this community strategy, we've been able to get a seat at some of those tables and really bring that community voice, bring a health equity lens to some of the conversations. And we've been able to see some real momentum grow there, which has been great. A couple of examples. So when the province shifted in the fall from walk-in testing to an online booking system, having members of the Ottawa Health team participating in those conversations, we were able to get immediately some low barrier testing options made available to phone numbers that people can call, so it wasn't just online booking, a plan for dealing with how walk-ins would be made available if that was the only way that people had to access testing, so that we didn't see a growth in those inequities when we went to online booking. So that was a really great example of how we've been able to impact at the system level, and also with communication. So with Ottawa's a big city. We've got a lot of moving parts with the pandemic response. So we've been working on a coordinated communication strategy that includes the hospitals, the pandemic response tables, our community response, and approaching it that way and bringing our voice to the table. We've been able to influence the direction that some of the communications have taken as well, to make sure that they're not just targeted at the general population, but they really speak to the concerns that have been identified by disproportionately impacted communities, and that equity lens is really applied to the communication products as well. So that's been nice to see. And next slide, please. And the last bit I'll talk about, it's not directly a component of our COVID community response strategy, but it's been something our OHT has been working on in parallel, is our Counseling Connect program. So Counseling Connect was born in the very early stages of the first wave, so back in the spring, and it brings together 14 different mental health addictions agencies from within the OHT partnership to really move the walk-in counseling model that we've had in Ottawa for some time online. So enable community members to access same day or next day single session counseling appointments, either over video or by phone. With a qualified counselor, these services are available usually within 24 hours. You can get an appointment booked. They're available across the lifespan in both official languages as well as some other languages as well. And we've recently been able to offer Indigenous specific counseling through a partnership with the Wabano Centre for Aboriginal Health. So this has been an immensely popular service and has been highly used throughout the pandemic. We've had over 3,400 either same day or next day appointments booked since our launch in May. 65% of those bookings were people making an appointment for themselves online, so not requiring any kind of referral. And 35% of the appointments have been referred through our partner organizations like the Ottawa Distress Centre, and we're working now at how do we expand that referral pathway to get more people connected with Counseling Connect, including our hospital emergency departments. And so that's all we have for you today. We're certainly happy to answer any questions that anybody has, and thank you so much for inviting us.
Thanks so much, both Leslie and Kelly. So now I'd like to use the remaining time to open up the discussion for participants to ask any questions or comments that they may have. I know Carrie's been monitoring the chat and question box. Carrie, is there anything to share?
Yes, I have a couple questions, and if others have some, please don't hesitate to write in the chat box, and I'm happy to read them out. So one question is to the Ottawa OHT. For efforts like the Ottawa OHT, do we know how exactly they organize their work? So I think, for example, how do they free up OHT employee time to do the work? My experience is that healthcare organizations know what needs to be done, but can't mobilize the resources to do it. So looking for a little bit of information from Leslie on those.
I'm actually going to defer to Kelly on this one, as she's been leading on the operations for us, and that's been directly something that she's worked a lot on, is the staff resourcing piece.
Yeah, So happy to answer that. It has been a bit of an effort, but it really was a call to action that was supported by our medical officer of health here in Ottawa to the lead agencies of the OHT, and then we have 60 plus other organizations that are part of our OHT, and we started with the 13 community health and resource centers and we hosted a meeting and we asked people to contribute what they could. We asked people to consider what they would normally be doing in their community, how that could be amplified. And so no one single organization has bared the load of any organizing or any holding any of this strategy. It really has been shared amongst multiple partners. And we have just pivoted the staff to do what we think is the most important work right now.
Thanks, Kelly. Elaine, I wondered if that question also resonated with you as you took on many different responsibilities as your role as both a convener of other homes and liaising with the Cambridge OHT.
Well, I think, very similar. I think what has happened in our community and through the engagement, I think it has brought us all together. And as I mentioned, Christina was more our point person. She's one person and she's so involved in so many things. So she's the point person, but then, as a community, we've come together, we've offered our resources. So for example, being a campus of care, we are able to offer resources to other smaller service providers. We're able to offer resources as far as what it's really like out there on the front line. And now as we're gearing to shelter care, we're offering resources there as well. And all of the partners of the OHT are doing that. They're all coming together. And I think that's that relationship piece. As relationships have been developed, everyone is saying, here's where I can help, and here are the gaps. And we're identifying those gaps in the community and coming together in that whole spirit of collaboration.
Great, thank you. Carrie, do we have time for one more question?
I think so. So the last question here is for Elaine and Christina, and it's, what did engagement with the OHT first look like? So I think prior to the pandemic, Elaine, getting a little bit of information from you about how you started engaging with the OHT from the outset, and maybe Christina, how the decision was made on the OHT side to start engaging with Elaine and her organization.
I have to say it was really scary, if I'm honest, because, all of a sudden there were going to be OHTs, and what were they going to look like? What was the framework going to be? And how, how should we be engaged? And so I think what really happened is there were some very key community partners who were involved in the beginning. And they started off by inviting, those of us who had been part of other collaborations to come together. We did hire a consultant who was really instrumental to work with our entire group. And I think for most of us, I know for our organization, for sure, we kept saying, where do we fit? Will we have a voice? What does this look like? And the deciding factor for us really was with regards to the frail, elderly, those that are vulnerable in our community, and that fit what our work is as an organization. And so that was really the deciding factor for us to become involved. Christina, do you want to add to that?
Just to add that I think that in principle, even in pre-pandemic, we had the intention that each partner at the table would have an equal voice, no matter their size. But the practicalities of how we've had to mobilize through the pandemic has really strengthened that and given that life. So that is one of those lessons in terms of engagement that through the process of the pandemic, we really have strengthened that and look forward to applying it in our next steps of our OHT development.
And that's critical, that everyone has a voice and has an equal voice, regardless of the size of the organization.
Sorry about that. Thank you very much for those great answers. So I would just like to bring this session to a close by offering a very sincere thank you to all 4 of our panelists, Christina, Elaine, Leslie, and Kelly, for sharing your insights with us today. They really brought this issue to life and gave us a lot to think about. If there are questions that haven't been answered, we will bring them to our online forum. It's the Learning and Improvement Collaboratives for OHTs, and there is a collaborative, a community of practice that's focused on patient and community engagement. So we will be happy to bring those back to that space and be able to answer those. The slides will also be posted online, and a recording of the session will be available. And on the previous slide, there are also a couple resources for community engagement and thinking through how to work through co-design. And just as the last slide, just wanted to highlight upcoming webinars next week on collaborative governance and additional resources that are all available on the RISE website. I'd like to thank all of you for joining us today, and many thanks again to our panelists for contributing to the discussion. Thanks, everyone. Bye.